Hello ladies and welcome back to my channel. My name is Aisha, aka Nurse Aisha. I'm a registered nurse here to spread awareness on preventative health and lifestyle choices for women. That is my focus so you can live a healthy and more informed life. I am so happy to have you back here today. I have a guest with me and I will introduce her quite shortly. But before I forget, please do not forget to subscribe, like, and comment on these videos, and also share to someone that might need this information. Alright, so today's topic is ADHD and depression. And I have Dr. Ruth Kizza with me from my community, my Ugandan community. That makes me proud, and this information is really close to my heart to inform my community specifically, but obviously this information is everyone. Let's get to it. Thank you so much for having me here in your beautiful setting.
You're
We
welcome.
are at Dr. Ruth's office
Yes.
here in the center of Stockholm, basically.
Yes. And thank you for inviting me to talk to our community and to other people who might have an interest in mental health issues.
It's my pleasure. It's my pleasure. So we're here today to talk about the important work that you do. You are a psychiatrist.
Yes, I am.
So please tell us, what do you do and how do you do it?
What do I do and how do I do it?
Yes.
That's a really big question. Well, maybe I'll start with what a psychiatrist is.
Yes.
So a psychiatrist is a person who's educated first as a doctor, or a psychiatrist is a doctor who is specialized in mental health disorders and what we call psychiatric disorders.
Yes.
So first I trained to be a doctor, I'm a doctor, and then you have a few years more of education and working with patients with mental health disorders.
So a specialist.
Yes, it's a specialist education, extra education as a doctor. So I look after people with mental health disorders, and also in a big part of it is also prevention. But usually by the time people come to me, they have some kind of issue that they need help with.
So it's a diagnosis already?
They have, no, they don't have to have diagnosis. They have a problem.
Yeah, okay.
They have a problem. And then what I then do is talk to the patient, get what we call a medical history, psychiatric history, which is what has your medical, how have you been all your life,
Evaluation.
Evaluation. We do an evaluation which includes taking a story of the person, how they're feeling, and how they've been the last few months or the last few years, and we go back as far as we can, and then also talk about their somatic or bodily health, how that is. We take tests, we take blood tests, we examine them, and then we also talk a lot about how they were as children and their family history of mental health issues, or of also some other bodily diseases or conditions that can affect the brain, so that you present with symptoms of mental health issues.
So physical health and mental health.
Yes. And also social. We do we call it the biopsychosocial approach. Okay. We take the physical health, the social situation, the circumstances of your childhood and where you are now, and even maybe where you want to be, how it is around you, how your social life is like, and that includes your occupation, your home situation, your family situation, and then we take the psychological issues, the stresses around you, and so we take a multifaceted approach to the
and how it affects you.
Yes.
Yeah. That is really good, because I usually talk to my community here on this platform, talk about how important it is to always have that medical background and not leave anything out. Because if you do, then it will affect the approach and how you go further to that. So I know that you have a specific, you have narrowed down your career and how you work and what types of conditions that you have chosen to focus on.
Yes.
So tell us, what are those?
Yeah. All right. I have, of course, psychiatry is I wouldn't say the love of my life, but something I'm very passionate about, and the whole of psychiatry. And I really, all the diseases, of course, I can treat and know how to treat. In the last years, I used to be, I have some darling subjects, and that is trauma, that is bipolar disorders, child and adolescent psychiatry, and ADHD. Of course, ADHD can also be child and adolescent psychiatry, and children can also have trauma and whatever. But that's if I just say my interests, areas of interest. But the last few years, I've been working particularly with ADHD.
Yeah.
And what was your question? Why?
I wonder why
ADHD? All right. Why ADHD? I like a lot of what we call biological psychiatry, which is almost all psychiatry, but there are things that we already have quite a lot of information, biological information. That means how the body and the brain, what's happening there to cause these diseases. And that's why, in a way, I also like bipolar disorder. And ADHD, I landed in ADHD because it's very biological. In the beginning, I worked with a lot of bipolar disorders, especially bipolar 1, in the inpatient setting. And that's when I came to Sweden, I mean. And then at some point, I had my kids were young, and I was offered an opportunity to start an ADHD, with a team. There was a team that had started in Stockholm here, an adult ADHD clinic within the public sector. And my boss thought that I would be a good addition to that team and asked me if I wanted to. And of course, since it's very biologically, and I had this interest, so that's how I started. Started with that, became totally, not obsessed, but I like working with ADHD. I love working with people with ADHD and autism. And that's what I've been doing the last more than 12 years or more.
That's a long time.
Yeah.
But if we could narrow it down and explain a little bit, at least for me, what is ADHD?
ADHD is attention deficit hyperactivity disorder. It's not a sickness, so that we can give you a medicine so that you can get healed from this illness. It's a condition that you're born with. Often it's genetic, that there's somebody else in the family, in the long family somewhere, who has had ADHD, or that there could be it could also be caused by circumstances around pregnancy and childbirth. So usually we'll ask about that when we're taking a history, as we call it. But other things also. But that's mostly it's genetic, and it affects our brains so that the person who has ADHD has difficulty in concentration, but not always. I usually call it like it's when a socket has a short circuit, that it's not completely, sometimes it's on, sometimes it's off, and you cannot control your concentration in the way that you need to achieve your goals. So maybe you're in class and you cannot concentrate at all, you're daydreaming and everything, and all of us daydream a little bit, but these people have big problem with that. So concentration problems and can't concentrate, even when they want to, even when they would like to be present in a conversation, their mind wanders away, so there's disorders of attention and concentration. There's disorders of regulating their activity, let's say. That's where you can have hyperactivity, that's where the hyperactivity comes in. But there are also others who are a little hypoactive. So it's not always that they're restless. Usually we think that ADHD is restlessness and running around, physical restlessness. But sometimes it's restlessness inside the head. There are a lot of people who say, I cannot switch off my head. I cannot switch off my thoughts, even when I'm tired and I don't want to. It's 1,000 thoughts going at the same time. Like,
I had someone describe it as popcorn.
yeah, they can describe it as popcorn or as a washing machine. I got even a tumbler. Like everything is just going around and it's difficult to grab just one thought and go with it. So
there's a million thoughts going on.
Yeah, and with some people it's a lot of impulsivity. And for some people it can be difficulty to get going. Task initiation. That to just start. You know you should do this and you really know and you really want to, but you cannot. And it's just until you have like
had enough.
Either you've had enough or you're threatened with in the last minute. You procrastinate up to that. You have a paper to write, 8,000 word paper, and you've known about this and you know about this, but every time you sit down, you can't. But at the very last moment, then because of what is happening in the brain, then the brain gets enough motivation, because now tomorrow you're going to be kicked out of school if you don't get this done. Then you'll spend an all night and then you will be able to concentrate very, very much. And get it done. So it's a disorder of attention and activity, regulating our activities, and also even if we don't talk about it so much, we know the people who work with it a lot and research in it, that do research about ADHD, is that there's a lot of disorders of emotional regulation also that come in. So people have hot tempers, easy to flare up, but also easy to be happy. Like they can sometimes describe themselves like yo-yos. Over one day, in the morning I'm really happy, and in the evening something happens, which others consider small happens, but a person can have such difficulties regulating their emotions, exactly as they have problems regulating their attention.
As you're talking about this, I'm thinking of so many people around me, both at work and my closest friends and people like that, even people that I've grown up with. This has been something. Being brought up in the 90s, before we started talking about ADHD, there were so many young people, because now ADHD is diagnosed very early.
Yeah, and ADHD has always been here. It's been here. I mean, it's been described, called kind of different names along the way, but it's been described in the science literature for a long time. And there's been treatment. Before, there was a big focus on boys, because there was a big focus on this hyperactivity, the physical hyperactivity. And then at that point, we believed that it was more among boys and less among girls. But now we know it's not that.
Yes, because now there's that debate about how women and girls are not being diagnosed.
Yeah, and because the expression of their inattention is not always similar to what we were used to with the boys, because even the girls, there are also a lot of girls who are hyperactive and whatever, and those usually get diagnosed early. But the girls who are more, there's the inattentive type of ADHD. The people who have that, a lot of girls and women have inattentive ADHD. They usually take a longer time to get diagnosed. Even the boys and men who have inattentive ADHD tend to take a bit longer than the ones with hyperactive. Of course, if you're disrupting everybody's life, everybody's going to point you out as a problem and try to get you fixed. But if you're just kind and sitting quietly in the class, but not there in your head, but not disturbing anyone.
Okay. So how is then ADHD connected to depression?
I can what we know. Okay, first we'll do just the epidemiology. Is that when the researchers have looked at studies of how many people have ADHD, how many people have the epidemiological studies in the community. There we see that people with ADHD are almost twice as likely to be depressed as people without ADHD.
Okay.
So you're going to find higher rates of depression, higher prevalences of depression among the people with ADHD than people without, almost double.
And why is that?
Why is that? Well, our theory is that when you have ADHD, you have a lot of negative consequences of ADHD on your life. Right from the beginning, because if we take childhood, if you're hyperactive, then you're going to be told off by people in your family, or you get a lot of negative criticism very early,
Feedback, yeah.
very very early in life, which affects your image and your self-esteem,
yeah,
and how you think about yourself and your abilities. Oh, I'm a troublesome child. I'm such a problem, because the teachers, the parents, the friends complain about you. But even the ones who are quiet,
yeah,
because of their inattention, you realize that, let's say in class, first of all, the inattention and the task initiation, and also to follow through what they call things. There's something called executive function. The executive functions that are usually affected by ADHD.
yeah,
The ability to follow through to plan and execute what you need. All those the different aspects of planning and task initiation, staying with the issue even if it's difficult, so that you can see it through. All those things are problematic for people with ADHD. So they can maybe not achieve as much as they actually know that they should. So usually in classes you hear, if he only wanted, if she only tried, if she only could, if she wanted,
quiet
she
down.
would.
Yeah.
Or maybe even if they're not quiet. If they're bright, this child is bright, but he's lazy, or she's lazy, or she doesn't care.
Sit still.
She doesn't care. She doesn't. They usually make silly mistakes in there, or maybe answer quickly, and they don't. When they turn over the page, they don't see that there are things on that side. So they underachieve compared to their usually intelligence level. So thinking, my goodness, what's wrong with me? Am I really, maybe I'm stupid. I can never, I know that, let's say, I know that I'm better, I understand these things better than Aisha. But when I come to executing, nothing happens.
Yeah.
So it's that negative feedback from school, it really affects, and even from themselves.
Yeah.
Imagine being at home, but not being able to wash your clothes. And then you get ashamed of inviting people home because you can't even clean your home. You know it should be clean. You want to clean it. You even get the vacuum cleaner and take it there, and then it's like something stops you from doing what
you get distracted.
You can get distracted, but you can also, you cannot. It's so boring that your brain, it's so not motivating for your brain that your brain cannot get you to do what you need to do. So,
Right, so then that leads you into sadness.
Sadness, disappointment about yourself, disappointment about not achieving. All the people say, getting angry with yourself.
So now we know why you chose ADHD. You seem to be very passionate about this patient.
I could speak.
You could speak forever, all right. But so the treatment program for these patients from the ADHD. Now you took the evaluation. You evaluated them, and you know what's going on, background, what's happening now, what they want to have in the future. So how is the treatment program then? How do you then give them the diagnosis? Because they could come into your office with something else. And I think behind the camera, we talked about people also wanting to minimize the problem, because apparently there's another condition very next to ADHD that is considered to be better. So they don't want to have the ADHD diagnosis. They want something milder.
No, it is ADHD, but ADHD can be the inattentive type or the hyperactivity impulsive type. The inattentive type has previously been called ADD.
Yeah.
And that one, for some reason, some people think it's better. It's not any better, I'm telling you, from the dysfunction that people suffer. But some people say, no, but I'm not I don't have ADHD, I have ADD, because ADHD maybe is associated with disruptive behavior and whatever, which doesn't have to be with everybody with ADHD. And then they think, but ADD maybe it's a milder form, but it isn't.
Because when I'm thinking about your patient group, I'm thinking about maybe someone coming in from a workplace where things are not working because of their hyperactivity or their non-hyper. Yes, so they're coming into you to get some type of fix, some type of help. And then now they don't want to be associated with this.
Yeah, it could be from the workplace, it could be from homes, because we have children and partners, because it's not working at home, things are stressful because they don't get life to work together. And that's what the thing is. You know, people usually say, oh, we all have a bit of ADHD. No, we don't all have a bit of ADHD. ADHD is a dysfunction. So when you have those symptoms to the degree that they negatively affect your social life, your home life, your school life, your friends, then that's when you asked about the treatment program.
Yes.
It's also a multifaceted. There's pharmacological treatment where we take medication, and there are medications that work very well for that, but it's not always enough with just medication. Psychological treatment, where you can get, either if you have issues that have come up secondary to your ADHD, so like anxiety and depression, or the ADHD itself, to learn how to cope with ADHD, how to manage stress in a way that makes you so that you don't get sick. Stress that's caused by ADHD. How to plan and execute, because usually when you have ADHD, you haven't got the ability during your childhood years or during the years you grow up to develop these skills. And now let's say that you get medication. Yes, it will help you to be able to concentrate, to be able to task initiate, but it will not help you to develop the skills that you did not be developed. So sometimes you need help either with a psychologist or with an occupational therapist.
Going back to the treatment. So my experience with ADHD in today's setting is young people, not toddlers, but young, very, very young children getting the diagnosis and getting the treatment. Medication. I haven't seen that they actually follow up with the whole what you just described. With that type of help with planning. Maybe they do it at school, but I do remember a close friend of mine who very early put their child on medication. And I had seen this boy grow up very, very hyperactive. I saw him as, someone with personality, very smart, very outgoing, very not maybe problem solving, but very quick. And I liked that in him because that was his personality. But maybe the parents hanging around him all the time, and also in school there was a lot of complaints. They put this boy on medication. And when I saw him, he had kind of dived down in a cave. And was no longer himself.
That's not the way it's supposed to be. Okay, if we first go back, I'm sorry for the people who just get medication and they don't get offered these other services, because they are important too. They are very important. So it's a failure for us medical professionals if we just offer people with ADHD with just medication. Medication works a lot and it's brilliant. I mean, it really can change people's lives, but it's not the only thing that you have to work with.
So what should parents do then?
They should ask their medical provider, excuse me, I would like help with structuring, help us at home, both at home and the child, with structuring, with if they're having emotional problems or problems controlling their tempers, or psychological help, and even for the parents skills training, or even just the parents understanding what is going on with a child, the need for structure, the need for routines, the need to have, you wake up at this time, you go to bed at this time, you eat breakfast, those simple things.
Okay.
So food, exercise, I usually say that it's a combination. Food, exercise, medication, and sleep have to work. Those 4 things, they have to work.
Yeah.
And you see, medication is only one of the 4 things.
Yeah.
And you talked about something that's also really close to my heart, this whole thing of, like, people would say that medication can kill somebody's personality. Then the medication is not right. Then the medication, maybe just that medication is not right for that person.
That was my first thought when I saw this.
Because maybe they need to change the medication. In that case, then I would like you as a parent or as an adult, I deal with a lot of adults with ADHD.
Yeah.
We usually talk about that because people say, but I know I saw somebody else, they took medication and they became strange. Or even people come and say, but I'm not as much fun as I used to be.
Yeah.
And then I'll say, maybe then the dose could be too high, or that's the wrong medication for you, that you need to change medications, you need to try something else, either a lower dose or change medication. Or talk to your doctor about it and explain. Don't just swallow everything. Because we're supposed to be treating the dysfunction so that the attention can get better, so that the task initiation and regulating activities, regulating emotions, and all the other things get better. We're not about changing the person's personality.
Yeah.
That's not what it's all about. And then, given that you will be maybe less impulsive, then you might be perceived as a bit different. I mean, maybe you want to get up on the table and jump up on the table and start dancing, like in the middle of like something else, because you'll be able to control your impulses. But you can still get up. The medicine should still be that I still want to get up on the table and dance, but now it is my choice. Not that I find myself up on the table dancing, doing things that embarrass me, but I can choose. It gives you that control over the impulsivity.
Yeah.
I usually say that it should still be that you walk past a shop and say, oh, what a beautiful, because that's your personality.
Yeah.
Oh, what a beautiful dress. Oh my goodness, I have to go in. You will go in and look at the dress and say, oh, but my budget doesn't really pass my budget.
So there's a fine line between your personality and the condition. So where do we see
where the dysfunction comes in?
Yeah.
Because if I'm so impulsive that I'm spending all my money without paying for my rent first.
Oh, okay.
Then that's a problem.
So that's the extreme.
Yeah. That's well, it's not extreme. There are people who will go and buy maybe a car when they cannot afford it, or they will go and buy makeup. It doesn't have to be a big thing. They will go and eat at a restaurant.
Yeah.
When they don't have really that because they don't even think about it.
Yeah, it doesn't matter.
Not that it doesn't matter, but in that moment.
Yeah.
Thinking about consequences comes later.
Yeah. Okay. All right. So now we left the ADHD, and now we're into the depression. So obviously, the depression rates, especially in this country, are high. Why do we think that is?
Well, with a caveat, they are also high in other countries. Depression rates in the normal, like the community, are very similar in most parts of the world. So why are they more here? I don't know if they are more actually, but we talk about it more. It's more open. We talk about depression more often, and maybe also because our society is such that it will take care of us when we're depressed.
So basically, we're being diagnosed here.
There's less stigma, there's more diagnosis, and also more support here than we'll get. There are a lot of people. I've worked in Uganda and have my friends and family still down there, both professionally and privately. And there's still a lot of depression. There's still people who commit suicide in Uganda. A lot of people. We don't hear about them because it's hush hush.
Yeah.
Here, when people commit suicide, it will be talked about.
Yeah.
There's no stigma, at least there's no family stigma attached to the family.
Yeah.
Or in most African cultures,
Mm.
it's an abomination to commit suicide.
Yeah.
An
And it's not
abomination.
documented. It's documented.
It's documented more, but we
There's
have
a
a lot of
database.
we have a lot of self-harm in Uganda. People who take poison
Mm.
to try and either as self-harm or as an attempt to kill themselves, but they don't manage. Maybe they don't get through. Or luckily, hopefully, and some of them get to hospitals, and then we will know about it. But a lot of these people never get into hospital.
Yeah. So now you went to the community
Yes.
part of these conditions,
Mm.
especially when it comes to depression.
Mm.
ADHD is it even talked about
Where?
back home?
Yes, I think it also societies the hyperactive and impulsive type is very easily seen.
Mm.
Those are I think we all know people in our communities who have been that child,
Mm.
you know. And long ago
Impossible.
when impossible, and unfortunately there's a lot of violence
Mm.
is committed against those children because they get beaten a lot.
Mm.
Because they get into trouble so much.
Yeah.
So then they get that trauma also.
Mm.
On top of that, but there we have ADHD I mean it's just a biological condition.
Yeah.
So we do have it, but the society, maybe we don't get so much dysfunction in many of the African societies because there are a lot of other things those people can then go and do.
Mm.
Here in Sweden, we have a society where your cognitive function and your executive function, there's a very high very high expectations for you to be able to manage your life in Sweden. You have to know you can read, write, make decisions, plan, because
and work together with others.
Work together with others. Many people with ADHD can also work together with others, but the expectations and the need for your executive function to be working well is much higher in these societies.
Mm.
Therefore, you get more dysfunction. Because if you cannot pay your bills,
Okay.
then you'll be in a lot of trouble.
So you get
You'll be
more
kicked out.
consequences.
Of
Okay.
your whatever. Whereas in Uganda, at least a lot of the people in Uganda don't have any bills that they have to pay.
All right.
You get a bill at home, you have to open the envelope, you have to pay it. No, you go, you pay your mobile service, you pay as you go. If you don't have it paid, you won't have that telephone. You won't have airtime. So it becomes easier even for people with ADHD to deal with their lives without getting a lot of dysfunction. Whereas
I love the fact that you've worked both in Uganda and here, and we're going to utilize that. So just to do these comparisons that you're doing. So now going to depression and mental disorders broadly, this is such a stigma in our community. There's shame and there's stigma attached to it. And it's basically always been like that and still that way. It's getting better, I guess, but very baby steps. Why is that, and how do we get past it? How should we? What are the steps to take? Especially maybe if we don't look at the so broad as in how the nation is gonna get through it, but in families, how do we get past the stigma and the shame?
I think a lot of it is education. And not education, like you said, not
awareness.
Awareness and education at even our community levels.
Yes.
To understand that this is illness, these are conditions, these are biological conditions, these are things that either, let's say ADHD, the person is born that way. Just as if I'm born with my skin color, it's nothing that I've done or not done to be that way.
Yes.
That's just the way I am. And then to say, okay, you're born this way, how can we help? How can you and the rest of us help each other so that you can thrive? You can also thrive, because even people with mental illness or conditions, other conditions, psychiatric conditions, they have just as big a right to thrive in our societies. So understanding as parents, as sisters and brothers, to understand this is a sickness. Just as when you have your cousin who has diabetes, you don't go around thinking, God, we will not talk. That one we don't invite to the party. Let them stay in the bedroom when the guests come.
Yeah.
No. So
But we do that on other diseases.
Yes,
Yeah.
Which ones?
Well, the physical, the physical disabilities.
Yes,
but that's a whole other story.
Yeah, that's another. Exactly. But to say this is something that that we have no control over. It's an illness. It can be treated. Some of them can be treated if they're not these neurodevelopmental disorders like ADHD and autism. ADHD can be treated, but some of the other things like dyslexia and whatever, there are strategies to work with them. But it's not. It has nothing to do with the person's intellect to understand that.
Yeah.
I think if we understand and we know that there's, in some cases, help, medication to be used and treatment of psychological treatment and other strategies that can be used, then the stigma will reduce. Yeah. To understand that it has nothing to do with intelligence and also to understand that it's not that parents who are bad parenting.
No. That is for a child. How about the individual themselves? Let's say like because I know a lot of people. I think in Uganda there was this joke where there was data that was published. I think you know about this. The 40%.
Which one?
There was
I think depression we had about 20%.
Yeah, there was a 40% of how a mental disease.
Okay.
There was
a 40%.
The whole country, and then jokes started, popping up that you're one of that 40%, and you are that 40%. And it became like a joke, which is really it's not a joking matter. It's not a joking matter,
and as long as we what is it called? We are nonchalant about things like that, then it doesn't really help us. The people who need treatment to know that there's treatment to be got, and that it can help. To psychological treatments, medical like medicines. That it can help, and it has nothing to do with your intelligence, with how smart you are, with how hardworking you are, with how strong you are. But I'm strong, I don't get depressed. It's like saying I'm strong, I don't get hypertension.
Yeah, exactly. I'm fit, so therefore I'm not sick. So I believe that acceptance is the problem. That's what I've seen. Accepting yourself that you have a problem is really a big problem.
Maybe it's not that you have a problem, but you're sick. This is an illness. Just like if I had COVID and I was very sick, I would go to a hospital, go to a doctor. Then it's the same thing. Or if I had pneumonia, I would go and seek help. To think that this is also a sickness. I can seek help.
And that it's very beautiful because that you say that. I met a boy a few years ago when I was in Uganda who had been to one of the very popular mental hospitals that we have. I think it's the only one.
Butabika,
yes. So he had been.
It's national referral.
Yeah, I would say he was locked up there, and he was put on medication. And when I met him, he was outside of the hospital, and they had regulated his medication, and he had a stable dose. Because I believe when he went there, he had some type of he had got into a psychosis stage or something like that. But what he told me was something that really stayed with me, and he was so I just felt for him because when all of his friends, the people that were in the room, were making fun of him, bullying him almost, and this is socially accepted to bully someone with such a very severe diagnosis. But then he turned to me and he said, "Aisha, I don't joke around with my medication. I see myself as someone with hypertension, so I make sure to take my medicine." And it was so heartfelt for me, and I stopped everyone bullying him and said, "Listen to what he just said to me." So I guess that him taking the medication was also a stigma around it, because now he's not quote unquote normal. He's crazy.
Yeah, and a lot of people then care about. So it's sad that people have to bully other. There are a lot of people. You'd go around the streets. I mean, when you reduce stigma,
Yeah.
it opens up a lot. First of all, it makes people it enables people to seek help and treatment, reduces suffering, both psychological and
Yeah.
also because they get their medication, get better.
Mm.
It improves their ability to go back to their workplace,
Yeah.
to their families,
Yes.
to function and be and just thrive in life. So
And you said that off camera is that you're not expected to be everyone who is functioning in the society. You said it so well. You can have a disability or condition and still function. You can be a doctor, you can be a pilot and have some type of...
You can be a teacher, you can be a baker, a mechanic, the streets, whatever, a mother, a sister, a brother, and have mental illness. And when you have treatment, usually you can go back to being what you want.
A second chance.
Yeah. A second chance. Just I really don't understand. Okay, I understand that is how we are as a group, communities, but I would like us to move away from that because I have a lot of wonderful people that I know with mental illness.
Yes.
Both taking their medications or who have had it and they've been lucky to get better completely, that they don't need medication, but a lot who will continue taking their medication throughout their lives.
Yeah.
And as long as they take their medications, they function well. So it would be very sad if people just don't seek help.
Them, yeah.
And you know, the worst thing is that some of these medical conditions are fatal. Depression can be fatal. People die of depression. People commit suicide because of that. People fall into substance abuse.
Exactly. Yeah.
And that also kills them. And of course, substance abuse, this is also another story.
Yes. Because what I've seen with substance abuse is basically numbing the problem. That is very, very common, especially with alcohol.
It's common that people use substances to numb their problems, but people can also start using substances for fun, and then it causes psychiatric illness. So it goes both ways.
Growing up in Uganda, I have some experience as a child, and I do remember being so scared. We had this one person in my I want to say village, but it's not a village, but in my around us where we used to live, we had this man, and he was considered crazy. And when I think about that now, I know that he had some type of mental health condition, untreated, undiagnosed, and not accepted in society. So he just run around in his psychosis state. He ran around and just made a mess of everything and disturbed everyone. And that is the only picture that we have, which leads to stigma,
maybe a lot of stigma,
and a lot of shame for the family around him.
Yes.
Why is this still the picture that we have of mental health conditions?
I think it still goes back to what we talked about earlier, education, information. We still need a lot to educate ourselves and our community about what mental illness is, what the treatment options are, and what can happen when somebody is treated.
Yeah.
Because I guess that guy that you described, who many of us, maybe if you've lived in some African country, have seen the mad people.
Yes, the mad person.
That's a severe mental illness. That's usually the extremes, and also because they haven't got treatment. But if those people are taken in and get treatment, then usually they recover.
Yes.
Either completely or to some degree, so that they're not dysfunctional anymore. And I think then we have only been seeing the extremely sick, and we think that is mental illness.
Yes.
But
and I cannot have a condition.
I cannot because I'm not like that man.
Yes, I don't look like that.
I don't look like that. But if we understand what depression is, what anxiety disorders are, what psychotic disorders are, because those are usually psychotic disorders, or people who have bipolar type 1, which causes then in the manic phase, the ones that we see around running around, like with psychotics, like they see things, they talk to themselves. That's extreme mental illness. But there's a lot of schizophrenia, which is also a part of the psychotic illnesses. So, but there's a lot under there before you get there. Before they got that sick, they started slowly. Slowly. So if we can easily identify the different, just like we have, just like we have hypertension, we have pneumonia, we have stomach illnesses, even in psychiatric illnesses, we have depression, we have schizophrenia, we have anxiety disorders, we have post-traumatic stress disorder. We have different types of illnesses, and different types of illnesses present differently.
And that post-traumatic stress syndrome that you talked about is very, very common, especially for a lot of people in the diaspora that come here as refugees, as
and,
war
because of war trauma, or even the trauma that people suffer during their flight from these
unsafe
situations, and even
and this is not nothing that we should take lightly. And if you only can talk to someone in your community or outside of the community,
and usually also now we're in Sweden, but also people who are living in different parts of the diaspora, go to your GP. That's where we start. Go to your GP. They usually, even at that level, can treat a lot of these mental health conditions, mental illnesses, before they get out of hand. They will at the GP level, they have psychologists, they can give you medication, and even occupational therapists in some areas. So there are resources, but usually we suffer silently, or we don't know that you can get help for this. You're sad and you're going around, you isolate yourself at home, you don't want to eat, but you think, well, I'll take a glass of wine to calm my thoughts. Instead of taking that glass of wine, which becomes 2 glasses of wine, which becomes maybe 3 glasses of wine every day, damages your liver, causes more anxiety, causes more depression. Instead of doing that, go and talk to your doctor. Or talk to a friend also in the beginning, who I hope will tell you go and talk to your doctor, but will also be able to support you in other ways.
That is really important that you said. If someone comes to you and talks to you about this, make sure that you guide them to the right place and not start, because in our community, them a bottle of wine. In our community we have this tendency of misleading people and guiding them to the wrong people that will.
They're bewitched, or they need prayers, or they need.
That is so sad. We see a lot of mental health conditions or people that should be on treatment in churches. In the witch doctor's hut or the witch doctor's home, because we don't have a lot of huts. I think they're a bit more modern. There's herbal medication.
And if you're willing to take yourself through that, why can't you just go and see a doctor? I'm not saying that people should not go to church or to their witch doctors. I have no opinions about that, but I have an opinion over that. If you have a mental health issue, get help from qualified professionals. But at the same time, seek help. I mean, when I lived and worked in Uganda, we were collaborating with traditional healers, because we know a lot of our patients seek traditional healers, because we guard, I'll go to the doctor, but I will also go to the traditional healer in case it was somebody who bewitched me. So I take the medicine and I also go to that. It's not sad, it's just their beliefs. Every system has a belief. Every community. But then to educate about, what is a traditional healer usually good at? They're usually very good at finding explanations of why. So that anxiety disorders, I think they're very good at treating, because they'll tell you to calm down, and they're very good. But we usually say, but don't take anything. Don't swallow. Don't take that, because that will clash with our medications, which we know. Our medications we know work. So If you want to go and pray, fine, if that's what you want, if that's your thing, but go to the doctor and get treatment.
Yes.
Go to a psychologist and get psychotherapy.
So now you're treating someone with in a full circle, from a social perspective, from a physical health perspective, from a mental health perspective, and then the community level guy joining.
And also that time we used to talk to the traditional healers. And I have a friend who also did a lot of research, a psychiatrist in Uganda, with mental traditional healers, and went and met them and talked to them. And also engage. Okay, now we don't have a lot of traditional healers here.
Exactly, you don't work that way.
But we do have the churches. We have a lot of churches and religious people.
Yes.
And there maybe that's a place that we could also inform, and so that people can know that if you see that person is, despite you praying for them or whatever you're doing, and they don't, can you please guide them also to the healthcare that can also help them together with you.
This was very insightful, Dr. Kizza. Very, very insightful. And I am so in awe with what you do.
Because we all do our part.
We do our part, yes. But when it comes to this topic, mental health, it's very, very, there's a lot of stigma around it. And I think a lot of people suffer because you cannot see this, you cannot feel that. When you see someone with a physical condition, someone bleeding, the wound, or someone, just maybe twitching with their eye, that is something that, you can maybe put in perspective. But when it comes to the mental health, it's still new, and there's so many nuances, and we don't really understand it, we can't really grasp it. So it's hard for many to accept. And I am happy that you came here and clarified a few things for us.
Thank you.
Not only from your medical perspective, but also from a community level and a social level. Thank you very much for taking your time to see about us and talk to us.
Thank you, and thank you, Aisha, for doing this, for making this possible, for getting the information out.
Yes.
Because it's a very, very important job that you're doing. Thank you.
Thank you. I hope to see you here again. And I hope to see you guys back here on another episode of Nurse Aisha. Please do not forget to subscribe, like, and comment. I would really love to hear from you and your experiences with mental health, with ADHD and depression. So make sure that you leave those comments in the comment section, and we'll make sure to answer them. Thank you so much for watching. Bye.
Bye.